I truly feel I'm a kind of a guest member of SOPANUP, and I always enjoy coming back. The subject I'm going to talk today, I'm going to talk more on concept than on technique. And we're going to discuss congenital nasolacrimal duct obstruction. I'm going to discuss 4 items concerning that. We will discuss first congenital duct rheocele, and I think that many people tend to put congenital duct rheocele with congenital epiphora, and it's a totally different problem. We're going to talk about probing, and I have my feeling about probing, and I'll tell you my view on that. Is it necessary? When and how? The next steps is what to do when it fails, and I think that will go faster. I'll talk very briefly about the congenital fistula or puncta laga, and then I'll give you a little trick that I have to take out retained silicone material if you happen to get one in your tear duct. The biggest question you should ask yourself when you see a toddler, and often you're going to be called in the nursery to see what the pediatrician thinks it might be an hemangioma, but when you see the location and the color and especially the feeling on palpation, you know it's a duct rheocele. You should ask yourself, is it unilateral or bilateral? And if it's bilateral, my view is that child should not leave the hospital before the problem is solved. I'll just give you a quick case report of that baby that underwent uneventful birth at 40 weeks with an APGAR, and that's important, that was normal. And he was referred to a general ophthalmologist for bluish masses in the medial canthal area on both sides. There was no other symptoms, and he was diagnosed with the duct rheocele and sent home for massages on both sides. We saw him at the pediatric hospital a few days later, and the duct rheocele both got infected, and in fact the child had been seen in a clinic for respiratory distress and just given decongestant. And when we saw him, he had some grunting and breathing problem. And that's very important because you can see here on the CT scan, this is something we would try to avoid now, but it was done. And you can see the big masses in the canthus. But also, if you go lower, you see that there's something prolapsing in the nose. And if you do a coronal, you will see that those masses are obstructing anteriorly both nostril. And these patients can get acute respiratory distress as they cannot breathe comfortably or efficiently through the mouth. And so you can do ultrasonography also to make the diagnosis and try to avoid CT scans, especially in a newborn. And you can see the masses here that are present. And we brought the child to the operating room. Can we start the video? And you will see that the diagnosis, in fact, can be done by directly looking in the nose. And what should be done in those cases is a decompression of the sac. And this is done here. You can see the prolapsing duct rheocele that is blocking the nostril. And endoscopically, it's very easy to take ENT's ear instrument and go and just open or marsupialize completely the duct rheocele. And this is done here on the right side, and you can remove the mucosa. And you will see that after that, once the mucosa is totally removed, you don't even need to intubate. This duct will stay open after. We can see here water now flowing through. Just taking out a little bit more mucosa. I cannot run faster the video, but you get the idea. And I just want to show you when we do the irrigation where it flows right through the duct. Usually the bone is deformed in those children, but at that age it will remodel completely, and 6 months later you won't see a difference between that child and a normal child. And we're just doing the same here, irrigating, and you will see that we get the fluorescent colored water going through. So congenital nasolacrimal duct obstruction is common in the newborn population. And you will see that, in fact, when we talk about congenital nasolacrimal duct obstruction, we will nuance that a little bit in my second part of my conference, as I have a feeling some of them have congenital epiphora but are not physically blocked. But dacryoceal is uncommon, but when it happens, nasal extension is often seen, especially if the dacryoceal is large. It's unilateral in 80% of cases, so there you can do some massages, but you have to be aware that you might have a small dacryoceal that is undiagnosed on the other side, or somehow it might become bilateral and then it becomes a different problem. If you do just a regular probing, there's probably a quarter of them that will reblock, because just making a hole in that thick membrane is not always sufficient. If you get the conservative treatment, in some studies the resolution is very high, but also the incidence of dacryocystitis is relatively frequent, and you have to realize that you're dealing with babies that are under 2 weeks old, and an acute dacryocystitis, if not well handled, can be life-threatening in those patients. But again, the key of this talk is that if you have a bilateral case, these can get acute respiratory distress, and they should be treated accordingly before leaving the hospital. It is possible to get infection like we had in our case, and then suddenly the dacryoceal will become much bigger. And if that's the case, these patients should be admitted in ICU and monitored, and endotracheal intubation might even become necessary if they get acute respiratory distress. So early and definitive intervention is important. Best modality of treatment, I would avoid CT scan in these newborns, as we want to avoid as much radiation as possible, and probably direct nasal evaluation with a little bit of decongestion will allow you to see the prolapse in the clinic and then in the operating room with the endoscope. So take home, when you have a dacryoceal, you should know that there's a relatively high risk of dacryocystitis. When it's bilateral, you should be monitoring the patient and do rapid treatment. And probably the best approach is to go intranasally and do a total marsupialization of the prolapse. Now, when I talk about congenital nasolacrimal duct obstruction, and this is my second subject, I like to talk more about congenital epiphora. And for me, clinically, the presence or absence of mucus on massage is very important. You will see that on my experience, if there's mucus secretion, it is most likely obstructed. But if there's only tearing, even if it's constant, and even if there's a little bit of mucus when they get a cold, maybe it's not blocked. And if there's any intermittency in that tearing without pus, then I can almost assure you that anatomically, although they're tearing often, they're patent. There has been studies done on the natural history of what happens to congenital epiphora between the age of 12 and 24 months. We were taught, at least when I did my training, we were taught that whatever happened at 1 year is what is going to be the case. So that basically if the epiphora hasn't stopped at 1 year, you need to do probing because it won't go away. Well, that's not true. In the study that was done in England, 30 of 50 of their eyes had spontaneous resolution between the age of 12 and 24 months. Now you will tell me, well, we always learned that if you don't do the probing before 18 months, you're going to have poorer result of probing if you do it later. There has been, again, studies done on that, and in simple nasolacrimal duct obstruction, you probably have the same final outcome until the age of at least 3 years. So you don't have to do it quickly to get better result. You can wait until 3 years, and you can wait if you don't have pus because you know that there's a high number that are gonna resolve spontaneously. So if we go back at what has been discussed before, you can see that in fact, doing probing in the clinic is certainly not necessary if you can wait, and doing probing in an infected case is probably not the best way to handle it. So that's another reason not to do office probing. My personal observation, in fact, has been that if there is mucus, it is blocked. If no mucus is present on massage, poor drainage is present. Maybe the turbinate are too big for the nose. I don't know where it's blocked, but anatomically they're patent. And if you have any intermittent tearing, it's always open. Now you would say, how can you know that? Well, I've been doing for the last 10 years of my practice when I was doing pediatrics, irrigation before probing. And I can assure you that exceptionally did I see a case where there was reflux on irrigation if there was no pus. And the other observation we had, our waiting list got very long, and in fact many patients, I'm talking before 10 years ago, were booked for probing, and by the time they got to the OR, at the age of 2.5, because of the waiting list, the probing had gone. So this is despite the fact that in the clinic I do very aggressive dye disappearance tests, and you can see that this child has retention, but I can see a little bit of color, and I do what I call the poor man's Jones test. If the child is old enough, and I ask them to blow, and I try to recover it. And this is a child that in fact is consulting for tearing, and you can see that in fact the fluorescein is going slowly in the nose. So the take home I would give you is that if suspect patency, there's no mucus, and try to get the precision in the history. Is it constant or intermittent? Is it daily or episodic? Check the puncta, test them carefully in the clinic, and if you have any doubt that you might have to do probing, you have until the age of 3 to do it, and you will see that many of them by that time will have resolved spontaneously. Proper probing, 3 rules. Be delicate. If you can't pass, don't insist. And rule number 3, bit delicate. Your goal is to open the valve, not to create a false passage, so that if you give those cases to residents, you should be there to supervise them and be sure that they do it carefully. I'll just show you how I do it. You see I dilate the punctum. I like to use the upper one initially. I think it's easier to pass in the tear duct from the upper punctum, and I do the irrigation before. If it's patent, you will recover color and you can wait, and they'll probably spontaneously improve by the age of 3. You should pass number 2O in the upper canaliculus and follow the plane of the forehead or the brow so that you don't go in the anterior ethmoids, and then you will feel it going down. And you should have the probe should be kind of tight between the brow and the tear duct. Otherwise, if it's kind of too anterior, you're probably pushing in the ethmoids. And the ethmoids are very fragile, so you'll have the feeling that you're in the good spot while you've just gone through. And then you should feel the metal-to-metal contact and do the probing to confirm that you've reopened the duct in the case where the obstruction was present. Additional procedure, I'll skip because I think this has been discussed before. I'm just going to discuss very briefly a situation we don't see too often, and it's the presence of those little openings that are almost always in the same location in the opening. And this is not a fistula from the sac, but it's really a persistence of a embryological ectoderm invagination growth that has canalized instead of getting atrophy, and that's called a puncta anlaga. And the treatment of that, it can be a fortuitous appearance. It can tear only when they get a little bit of nasal congestion, or they can get infection and constant tearing. And it's due to that embryologic ectoderm pattern where the duct forms from the migration of the surface ectoderm in the tissue to form the tear duct. And usually that canal should atrophy, but in some persist. Indication for removal are if there is epiphora, and you have to be ready to deal with a lower obstruction that is sometime present when they have epiphora through their fistula, and that might need removal of the fistula and nasolacrimal intubation at the time so that it doesn't scar. Some of them get recurrent infection or mattering with keratin debris, and then they should be removed. This is an example of what I call a puncta anlagatitis, where he gets kind of an acute dacryeus cystitis, but inside the fistula on a regular basis. So this should be quieted down with ointment and maybe systemic antibiotics and then excised. This is another example here where an older child has a constant epiphora through the fistula, and this is an indication for removal. And if you want to remove them, you should put a probe inside and do really an excision of the tract down to the sac and intubate the lacrimal system, otherwise you're at risk that the scarring will occur, and close it in 2 planes. And don't try to cauterize it, it just doesn't work. You have to remove it and close it. Now a little trick I have for you. What happens, you see that once in a while, where the tube has come out. Most of the people will tell you that it has been irritating their eyes, and then sometimes Uncle Ben decides that he's going to handle the problem and takes a nail clipper and cut both ends. And then you're caught with the knot inside the duct, If you wait long enough, you're going to get a foreign body dacryocystitis. The clinical or the classic teaching has been to remove those by doing a cysto-rhinostomy, because you need to open the duct, and if you open the duct, it's going to scar, so you need to do a DCR to go and take out that foreign body. Let me give you a trick I had when we had one of those cases. We thought maybe we could try to clean the chimney, and the technique is to use the Crawford system and to intubate the system through the same canaliculus so that you form a loop that you can pull inside the nose. You can see here the first tube has been passed, and we go back in the same canaliculus, and just beside the tube we intubate, and we have a loop now that is becoming our chimney cleaner. And you get both loops down, and surprise, the knot will come out. We've done 4 of those cases, and it worked in 4 of them. So next time you're caught with a knot caught inside the nose, try my little trick of cleaning the chimney. We could maybe try it on a punctal plug that have been migrating instead of having to open the duct, but I haven't had any of those cases. I hope that those little tricks help you. This syndrome of retained tubes will give you a very special triad of a case where there has been an intubation, you have mucopurulent discharge, but if you do irrigation, usually it's patent. If you have that triad, you should suspect there's a piece of silicone in the nose, and I would suggest you try my cleaning of chimney technique. Thank you.